For our third presentation, I would like to welcome up Dr. Luis Paz Ares from the Division of Oncology, University Hospital, Virgen del Rocío, Seville, Spain, to discuss his abstract on nivolumab versus docetaxel in non-squamous cell, non-small cell lung cancer. Thank you.
Mr. Chairman, dear colleagues, ladies and gentlemen, it's a great honor for me to present today, on behalf of all the CheckMate 057 trial investigators, the result of our trial comparing docetaxel versus nivolumab in patients with advanced non-squamous non-small cell lung cancer. Here are my disclosures. Treatment options for patients with advanced non-squamous non-small cell lung cancer are pretty limited, particularly when patients had already failed to platinum-based chemotherapy. Typical response rates to docetaxel in this context are 10% and expected survival in the range of 8 to 10 months. Nivolumab is a fully human IgG4 type monoclonal antibody directed to the PD-1 receptor that has shown encouraging activity across different subtypes of non-small cell lung cancer. Recently, the drug has been FDA approved for the treatment of squamous cell carcinoma of the lung on the basis of a randomized phase 3 trial, whose results would be also presented here at this meeting. As mentioned before, by interfering the binding of PD-L1, PD-L2 to PD-1, nivolumab actually inhibits the inhibitory PD-1 signaling and therefore restores anti-tumor immunity. Here are the main inclusion criteria. 582 patients were included, all of them advanced stage, non-squamous histology. That was an all-comer status in concerning PD-L1 expression. So we didn't measure PD-L1 expression at study entry, but acquisition of tumor sample were mandatory for all patients. Good PS, all patients had failed prior chemotherapy based on platinum doublets, and prior maintenance therapy was allowed, as it was TKI treatment in case of ALK rearrangements or EGFR mutation. After stratification, patients were randomized 1:1 to nivolumab, 3 milligrams per kg every 2 weeks versus docetaxel at a standard dosing every 3 weeks. Primary endpoint in this trial was overall survival. Other endpoints include response rate and PFS assessed by investigators, safety, and also correlation between efficacy and PD-L1 expression in tumors. Quality of life was also an endpoint whose data will not be presented at this meeting but an upcoming meeting. We hypothesized that median survival with the nivo treatment would be 9.8 months as compared to 8 months with the standard of care docetaxel. 442 deaths ensured overall power of 90% and a 5% type 1 error with one interim analysis to show the difference in survival previously outlined. The interim analysis for superiority requires a minimum of 380 events to be performed, and that was actually performed with 413 events. 93% of those required for the final analysis. With the result of this interim analysis, the DMC declared the superiority of nivolumab as compared to docetaxel in this context, as the trial had met the pre-specified criteria for the superiority on the interim analysis. Patient characteristics were well balanced between the two study arms. There was somehow higher median age for patients on the docetaxel arm. As well, the number of males, the proportion of male, 58% was higher, 52% on the nivo arm. Some 80% of the patients were smokers. All of them had received prior treatment with platinum-based chemotherapy, and some 12% of the patients had received other line of treatment, mainly TKIs, as I commented before. 40% of the patients had received maintenance therapy. Importantly, we were able to quantify tumor PD-L1 expression in 455 patients, 78% of the patients. PD-L1 expression was evenly distributed between the two treatment arms. We found that It was expression of PD-L1 in 1% of more of the cells in about 55% of the patients. Expression was present in 5% of more of the cells in about 40% of the patients, and in 10% of more of the cells in about 35% of the patients. Here are the main results of this trial. The Checkmate 057 trial met its primary endpoint. As you see in the depicted curves, overall survival was improved for patients treated with nivolumab as compared to those treated with docetaxel. Hazard ratio being 0.73 and a p-value of 0.0015. That means there was a reduction of death all along the study period of about 27%, and that corresponds to an improvement in median survival of about 3 months. 9.4 months for the taxel as compared to 12.2 for those patients on the nivo arm. Benefit in survival with nivolumab treatment were seen all across most of the study groups, regardless age, gender or PS. We did not see such a benefit in two small subset of patients with EGFR mutation or those that were never smokers. Even those subsets were pretty small in this trial. Response rate was also improved with nivolumab treatment. 19% as compared to 12% with docetaxel, with an estimated odds ratio of 1.72 and a p-value of 0.0246. Most of the responses were partial, and interestingly, response duration was also prolonged on the nivolumab arm. Median time of response was 17.2 versus 5.6 months. We did not observe difference in PFS in this trial. Indeed, progression was more rapid for nivolumab-treated patients during the first 6 months and more slowly thereafter. In fact, the progression-free survival rate at 1 year was 19% for nivo as compared to 8% on those patients treated with docetaxel. PD-L1 expression emerged as a significant predictor factor for outcome on nivolumab-treated patients. As you see in the slide, for PD-L1 positive expressors with 3 different cut point levels, 1%, 5%, and 10%, the magnitude of the benefit in survival for patients treated with nivolumab was higher than in the overall population. Actually, response rates were ranging from 0.59 to 0.40, and the corresponding median survivals on nivolumab-treated patients with PD-L1 positive expression was unprecedented in this setting. More than 17.2 months to more than 19.4 months. On the contrary, for PD-L1 negative expressor, we did not see difference in survival between the two study arms. The magnitude of the benefit for PD-L1 positive patient on the black dots was quite evident, not only for survival but also for PFS. On the contrary, on the red dots, this benefit was not seen for PD-L1 negative expressors. On the last column on the right, you see the interaction p-values for interaction tests, which more formally confirms there was an interaction between PD-L1 expression in tumor and treatment effect, all values being highly significant. PD-L1 expression was also a predictor for response. Actually, response rate was as much as 3 times higher with nivolumab as compared to docetaxel on those patients with high levels of PD-L1 expression, regardless the cutoff point we have used for this comparison. Median duration of treatment was about 12 weeks in both treatment arms. 6 cycles of nivolumab every 2 weeks, 4 courses of docetaxel every 3 weeks. The dose intensity delivered was higher for nivolumab, and interestingly, the number of patients receiving subsequent therapy, post-study therapy, was 42% on the nivo arm as compared to 50% with docetaxel. The incidence of treatment-related adverse event was higher for patients on the docetaxel arm as it was the severity of these AEs. For example, treatment-related serious adverse events were recorded in 7% with Nivo and in 20% of the patients with docetaxel. Consistently, AEs leading to discontinuation were recorded in 5% with Nivo as compared to 15% of the patients with docetaxel. Very few toxic deaths were seen known on the nivolumab arm. Here we have listed all AEs recorded in at least 10% of the patients. As we have said before, the incidence and severity was higher with docetaxel. 69% of the patients had any grade AEs as compared to 88%. More importantly, grade 3-4 events were seen in 10% of the patients with Nivo treatment, but in 54% of those patients treated with docetaxel. For all the items listed here, severity and incidence was higher on the docetaxel. Most frequent adverse events were fatigue, nausea, and hyporexia for nivolumab. All those three events were also very frequent with docetaxel. In addition, frequent events were diarrhea, neutropenia, febrile neutropenia, and alopecia with docetaxel treatment. We here have listed those adverse events typically linked to immunotherapy. They were of low incidence and low severity. 7% hypothyroidism on the Nivo arm, 3% pneumonitis or transaminitis, and 3% of the patients in each arm had high sensitivity reaction. Nivolumab is the first PD-1 inhibitor to show improvement in OS with nivolumab treatment as compared to docetaxel in the setting of previously treated patients with non-squamous, non-small cell lung cancer. We have observed a decrease in the risk of death of 27% and improvement in median survival of 3 months. Response rate was also improved with nivolumab, and PD-L1 expression was actually a predictive factor for nivolumab treatment, not only for survival but also for response rate. Survival was doubled for patients treated with nivolumab and response tripled for patients with PD-L1 expression. On the contrary, this effect was not seen in PD-L1 negative patients. Safety was more favorable for nivolumab as well, and this is the second trial to show an improvement in survival for nivolumab as compared to docetaxel in advanced non-small cell lung cancer. Thank you to all patients contributed to this trial and all other people involved in this trial. Thank you very much.